Hello, thank you for joining me for the Mentor Program Clinical Pre-Lab on the lumbar spine. Course objectives are as follows. Participants will be able to identify current literature regarding physical therapy diagnosis and interventions for lumbar dysfunction. Participants will be able to utilize diagnostic values for clinical decisions. And participants will be able to identify key biomechanical and anatomical components in the diagnosis and treatment of lumbar dysfunction. Fritz and al., in their study looking at subgrouping patients with low back pain and the evolution of classification approach to physical therapy, they noted that approximately 50% of all patients that present to outpatient physical therapy clinics have low back pain. And if we look in the Guide to Physical Therapy Practice, there is a wide range of interventions and management in patients with low back pain. So one of the things that we need to do as clinicians is utilize the three principles of treatment. This includes the best evidence that's out there, and we'll touch on some of that today, your clinical experience, as well as patient values regarding certain treatment approaches. Clinical prediction rules are algorithmic decision tools that are designed to aid you, the clinician, in determining the diagnosis, the prognosis, or a likely response to an intervention. That was according to Glenn et al. They often take clinical findings from the history or physical exam or diagnostic test results and determine what factors would most likely affect that diagnosis, prognosis, or intervention. Also, test item clusters can be used as diagnostic clinical prediction rules. Some familiar ones, lumbar and SI joint manipulation. We have lumbar stabilization success. We have lumbar stabilization failure, as well as diagnosis of SI origin pain. And as we know, the spine may not be for everyone, but hopefully after today's pre-lab and the lab session, you'll have a better understanding on any areas that you may feel a little weak in. So one of the things we're going to focus on is treatment-based classification. So why do we want to look at treatment-based classification? Previous research has primarily looked at patients with back pain or neck pain and basically lumped them into a very large group. Because of that, the results that were found in these studies were often insignificant. Clinicians recognize subgroups, but these subgroups had not necessarily been identified in the literature. We often noted that signs and symptoms had a particular pattern that we were able to recognize. And we found that when patients are classified into treatment groups, the outcomes are improved. And so what does that lead to? Well, usually, if we're matching the correct treatment to a particular classification, the patient is the one that ends up being very, very happy. So we do want to touch on one of the studies, and it's identifying subgroups of patients with acute and subacute nonspecific low back pain. And this study was looking at comparing outcomes of patients with low back pain receiving treatments that are matched or unmatched to their subgrouping based on initial clinical presentation. So these patients underwent a standardized examination, and at the end of the baseline exam, data was used to classify each patient using the decision-making algorithm used for subgrouping patients with low back pain. Once this classification was completed, it was compared to the randomization treatment group, and if the subgroup matched the treatment group, they were considered matched, and if they did not, they were considered unmatched. So the treatment followed the baseline examination, and the patient was referred to a different therapist for the treatment. The randomization was also performed by a third party assigned, and the patients were assigned to a manipulation group, a stabilization group, or a specific exercise group. The manipulation group performed one of two specific manipulation treatments. One was in supine or one was in sideline. The specific exercise group followed repeated range of motion exercises into flexion or extension, and the stabilization group performed trunk strengthening and stabilization. This is the basic algorithm that was used within the study, and you can simply follow the questions and the classifications into the group, as well as the manipulation, stabilization, and specific exercise categories. The disability was assessed at 4 weeks and 1 year using the Oswestry, and comparisons were made between patients receiving treatment that was matched to their subgroup versus those receiving unmatched treatment. They had 123 patients participate, and they noted that the matched treatments experienced greater short and long-term reductions in disability compared to the unmatched treatment groups. There was a 6.6 point Oswestry change at 4 weeks and 8.3 points change at 1 year. So one of the things that they also noted is that was persistent disability increasing among patients who failed to recover quickly with low back pain. The initial treatment window is very important, and with improved decision-making processes via subgrouping, this may have a long-term implication on a patient's well-being. We do want to touch on some other aspects of not only treating the low back, but as you'll find, all areas of physical and occupational therapy intervention. One thing to think about is what are termed as pathological barriers of motion, and the 4 pillars of treatment or assessment. And they consist of the muscle, joint, fascia, and compensation. So when you think of muscle, you're basically looking at, I've got someone that has low back pain, perhaps L3, L4. The first thing you need to do is basically clear out all of these areas. So you look at muscle, okay, what muscle is attached to the lumbar spine? In this example, you think immediately, okay, iliopsoas. So you look at the origin and insertion of the iliopsoas to determine if there's any dysfunction that could be affecting the muscle, creating a hypertonicity and perhaps creating some segmental rotations at the spine, causing altered joint mechanics. So these altered joint mechanics, if you have someone that has very specific joint pain, we need to figure out what's going on with the joint. Is the joint have a loss of motion? Is there an abnormal joint mobility? Is there hypertonicity of the muscles around the joint? And that will help us determine what treatment approaches are going to be the most effective to treat that patient with. Fascial restrictions, primarily we think of these with regards to surgery. So with the lumbar spine, if we're dealing with someone that's had a posterior approach to the lumbar spine, we know that we're cutting through multiple layers of skin, fascia, and muscle, and all of that has to heal up. And at times, that healing process can get interrupted, or it could certainly not occur in the normal fashion that it needs to, and so you get fascial restrictions or scarring, which can lead to range of motion, joint mobility, and muscle deficit. So again, we need to address the fascia. Compensation primarily deals with is really what I tend to see as a result of those the other 3 pillars. If you've got limitations to muscle, limitations to joint or fascia, you tend to start to see a compensatory pattern in movement that is abnormal. When we're thinking about pain, symptoms of pain can often be in a different area than where the dysfunction may be located. So again, that kind of takes us back to the pillars of treatment, but when we're thinking of low back pain or SI joint pain or something along there, or maybe a piriformis syndrome, their pain may be in a particular area that is not where the dysfunction is. So our job as clinicians is to find out where is that dysfunction. Perhaps the patient that has a piriformis syndrome is really having has biomechanical issues at the foot, and is creating constant overpronation and internal rotation at the tibia and the femur, which is putting excess stress on the piriformis, thus creating pain and limitation. So again, we need to make sure that we're looking in multiple areas to try to determine where's that dysfunction so that we can address the pain correctly. We need to understand what the differences between hyper and hypomobility symptoms of pain are, and that will help us determine where to look. And with respect to kinematics and biomechanics, minor joint dysfunctions are often found in the latter portion of the range of motion, and major joint dysfunctions are often found at the early part or even throughout the range of motion. The hypo-hyper compensation model basically states that hypomobility in a given area will cause a compensatory hypermobility or hyperactivity in another area. The hypermobile or hyperactivity area is typically the one that is symptomatic or very painful. But as I described just a moment ago, that hypomobile area is the area that really needs to be treated so that we can decrease that hypermobility or that hyperactivity. And in this chart, we can see some of the signs and symptoms regarding hyper and hypomobility. With hypomobility, it tends to be less painful, 5 out of 10 or less. It's kind of that deep, dull, achy type of discomfort or pain report, and that's because it's stimulating cartilage, and you get a proprioceptive crossover. Usually, the referral pattern is in a small area. With hypermobile symptoms, it's typically that higher level of pain, greater than 5 out of 10. It's usually more sharp in nature, and that's because we've got micro tearing of tissue, and this stimulates the nociceptors. You typically will get a farther referral pattern, and this will stimulate muscles and ligaments and capsule nerve, vascular, everything. So you get the more tissue that's involved, you get a larger referral pattern. Specifically with the spine, and not only dealing with the spine itself, but also with lower extremity dysfunction, we need to make sure that we're clearing the different segments that could be affecting the mobility of the lower quarter. The quadriceps typically is affected by the L3-4 nerve root, tibialis anterior L4, gastrocs L5 and S1, and hamstrings S1. So again, you can take this back to your pillars of treatment and assessment. If you're dealing with someone that has quadriceps dysfunction, it's important to go back and look up at the lumbar spine, because the lumbar spine could have a dysfunction that's creating that hypomobility or hypoactivity of the quadriceps, and that could be affecting the patellofemoral joint. So important to know your segments and to clear those segments whenever you're doing an evaluation of the spine, either for the lumbar spine or for a lower quarter dysfunction. When we look at the pelvic girdle, there is a school of thought that looks at a particular treatment order for the pelvic girdle, and it's listed here on the slide. And typically, what we want to do first is do a pubic symphysis clearing, because clinical experience and osteopathic treatment approaches demonstrate that if the pubic symphysis is either positioned one side positioned superiorly or inferiorly or anteriorly or posteriorly, that tends to change the entire mechanics of the entire pelvic girdle. So if we don't clear that first, and often looking for that cavitation, this can basically lock up the pelvic girdle and cause abnormal joint mobility. Our next area to look at is iliac upslips or downslips. Downslips typically are going to correct on their own through weight bearing, but your upslip can not only affect the pelvic girdle, but also can affect the upper quarter, namely the shoulder, with regards to shoulder impingement. We know that the thoracolumbar fascia comes all the way through from the ilium up through the latissimus dorsi and through the anterior pectoral muscle and fascia, and attaches to the clavicle. And so the clavicular jump test will be positive if you have an upslip on that same side, because you are dealing with changing the length tension relationship of that fascial component. Ilial flares, so basically you're getting an inward or an outward flare, and again this can affect length tension relationships with regards to the muscles that attach to the pelvic girdle. One of the most common things that you will see are ilial rotations, either anteriorly or posteriorly, and again what we're dealing with, these are primarily going to be functional leg length discrepancies. You go in, you do a pubic clearing, you may see an upslip or a flare. If you do, you correct those. Then you move to your ilial rotation. You can certainly use muscle energy techniques or joint mobilization to correct the anomaly. And again, when you're dealing with ilial rotations, keep in mind that even if it's a few millimeters, it is going to change the length tension relationship of the muscles. And so if we think of the cross bridges of the actin and myosin, if we've got a muscle that is in a lengthened state, the actin and myosin fibers are not going to be able to perform, or not going to be able to attach the cross bridges effectively, which is going to affect strength. So you may notice that a patient has weakness. The same thing is true as if it's in a shortened state where the cross bridges are overlapping and are not going to be able to attach correctly. And so again, you will notice weakness of the muscle. So is the weakness due to muscle strength deficits, or is the weakness due to inhibition or length tension relationships? So these are things to consider when dealing with pelvic girdle dysfunction. Our next step in this lumbo-pelvic girdle dysfunction algorithm is looking at your lumbar spine. So you can individually look at your lumbar segments and look for segmental rotations, or look at PA glides to determine if there's any kind of hypomobility or hypermobility to the individual lumbar segments, or you can simply go in and do a lumbar clearing to clear the lumbar spine. Sacral dysfunctions, this is often an area that people tend to forget. And usually when they think of SI joint dysfunction, they primarily stop at the ilial rotations. And granted, with the ilium and the sacrum interacting, that can certainly cause a lot of complaints to the SI joint. But if the sacrum is nutated or counter-nutated, or a forward or backward rotation or torsion, it is going to affect, again, that length tension relationship of the piriformis and any of the muscles that attach to the sacrum or to the hip. So you can deal with hip issues, you can deal with SI joint issues. If you're having SI joint pain, we know that the intimate relationship between the sacrum and the spine, it can cause low back pain. If there's a sacral torsion, the piriformis can be affected and its length tension relationship, and so that can lead to altered compensatory control of the lower extremity during gait, and primarily being able to slow the internal rotation of the limb. So make sure that you're specifically looking at the lumbar spine, the sacrum. There's multiple ways to look at it through PA glides, palpation testing, seated and standing sacral testing, and a multitude of other special tests. So it's important that what you need to do is to assess them and treat that area to make sure that you have the appropriate length tension muscle relationships and joint mechanics. So overall, in summary, when looking at the lumbar spine and, in a sense, the lumbopelvic girdle, look at the evidence and see what's out there. We've got a multitude of clinical predictor rules. We've got treatment-based classifications. There are test item clusters. It's important to use the evidence, classify your patient if possible, because again, we know that if we can match our patient to a particular classification, the outcomes have been demonstrated to be more significant. And again, if you're struggling and your patient is struggling with regards to, they're continuing to have pain, they're seeing improvements in their mobility and pain, but they're not, crossing that threshold to where we expect them to be, make sure that you're thinking outside the box. Make sure you're getting in and looking at all potential areas as we look back to the pillars of treatment and assessment: muscle, joint, fascia, and ultimately compensation. That we've addressed all four of those areas with whatever techniques or tools we have at our disposal: manual therapy, soft tissue mobilization, muscle energy techniques, joint mobilization, dry needling, ASTIM, whatever we need to do, that we use it all, and we use it all in the appropriate areas as needed to address any potential dysfunction and hence get our patients back to normal function. Thank you.